Well, welcome everybody. For those of you I might not have met, I'm Michelle Oshman. I am the Chief Patient Advocate here at I like to say Bio Galactic Headquarters in Washington, D.C. And I think all of you know the Senior Director from our team, Karen Heltzer, who is uh, absolutely stellar, and she'll be leading the policy conversation today. But what we wanted to do was kind of bring back one of the features that we have historically started off with for the coffee chats, and that really is introducing new and incoming leaders from nonprofit organizations to the community. So with that, I will introduce you all to Kristen Kiefer, who is certainly no stranger to so many of us who have worked in aging and in this space over the course of many years. But you joined just earlier this month as the Generations United Executive Director. So thought I would ask just a little bit about, if you don't mind sharing your background. I know we met when you were at NCOA and the work you've done at Leading Age, among so many other places. And I know you and Sue know each other well. But if you could just share a little bit about yourself, and then for the group, share a little bit about Generations United, since some of us may not be as familiar.
Absolutely. Well, thank you so much, first of all, for having me. And I have to thank my board member, Janet Mikulski, as well for, connecting you and me again, Michelle, and getting us here today. So I am on day 12. So I know Michelle's going to go pretty easy on me today. But my background is really rooted in health, business, and public policy. So I came out to Washington to pursue public policy, did a short stint while in grad school on the Hill. And really realized that the aging services space was a passion because I grew up with the mentality of being of service to others. And what better impact can you have but at a national level? And so, as Michelle alluded to, I've spent much of my career in aging services spaces, from Gerontological Society to Leading Age, and 18 years at the National Council on Aging in many capacities. With the most recent being the National Advocacy and Engagement Officer. I then took some time myself off to do some personal caregiving, which I know this group can appreciate, and also realized that I wanted to get some tools in my tool belt and really work at the community level where the action, in the real work really happens. So I was able to oversee and be executive director where it was really about community engagement. It just happened to focus around the historic district and economic development. But through that experience, I was able to figure out how do you get folks in your own community, and this was my community, my backyard, where I raised my family, to be the ones that help make the change and help to determine the transformation and the next iteration of what our city should look like. So then the dream happened. All of my worlds came together. I also have experience on a school board. So, had a chance to see challenges families and children and people of different cultures face in terms of access. And then the Generations United, Donna Butts, who I adore and is just such a wonderful person who's built this organization, is on to her next chapter. We don't call it retirement, right? And my worlds kind of merged in where how do you really kind of take the continuum of the life cycle and really figure out how to have health access, education access, whatever that access or the supports needed to ensure access for everybody who may not have a voice was heard. And so it's just a natural, part of the evolution of me as a professional and a personal.
Oh, excellent. And again, I know so many of us have shared contacts and shared experiences. So we're thrilled to have you. And a couple of things that I found out about you as and both from recollection, but also looking a little bit online. In addition to having your Master of Public Policy from Georgetown and your dual bachelor's in Health and Business from Ohio University, which is not the Ohio State University.
Oh, no.
Ohio, never to be confused. I have learned that the hard way. But you hail from Cleveland, and you're one of the blogs that, or maybe the Generations United piece said, Kiefer is a proud and unapologetic Cleveland sports fan. So tell us a little bit about, are we baseball? Are we football? Is there some, what's the draw, and what's your favorite team? And what's
well, I would say I always love the most losing teams. Being a Cleveland fan, it really doesn't matter which one I love. But I do have a son who plays college baseball, so I do love baseball. But in my family, the one thing we can agree on is the football team is the Cleveland Browns. So, I've been there for all of the sorrows over the years, and I will remain
Yeah.
the Cleveland Brown fan that I am. So,
Well,
yes.
that's fantastic. I think I just did a little bit of research. The Cleveland Guardians are 12 and a half games back in the AL Central, still much better off than my Orioles, or as we call them here, the O's.
We're a split family. We're Orioles and Guardians, so it's a little rough.
Okay.
Yeah,
Yeah.
I can empathize with
Yeah.
you though.
I had the good fortune to be at a Nats game last week, and I have to say I'm really an American League girl. But you also the only major league pitcher named Slade Kiccioni. So congratulations on having a really cool name. One of the other things, it said that you enjoy spending time with your family, traveling, cooking, and you find happiness in being near the water. So tell us a little bit about that.
So I grew up in a small town just west of Cleveland called Vermillion. So if you know where Cleveland is, you know where Cedar Point, the amusement park is, I'm somewhere in between. Small, just right on the lake. It was always my place, no matter what was going on in life, and still remains that as kind of my refuge. So I hope that when I go to my next chapter in life, I can do a little more cooking than I'm able to do right now with the busy life. But it's worth it. In fact, Generations United is Grandparents' Day is coming up. So any of you who still are lucky enough to have a grandparent around, don't forget to wish them that. But we're doing videos that, really share the experiences we've had with our grandparents around food. So you're gonna see some videos there, but we really are about, programs and policy and all kinds of things that just encourage and empower generations to be together in a very intentional way. So it's not just about saying, let's live together or let's, do one thing together. This is a way of life that we as a country can solve so many societal issues for, whether it's health, education, access to legal services. So it's just there's just so much more room for so many of our groups to just come together around so many issues.
Absolutely. And I think when I first learned about Generations United, which again is from Janet, I first thought of it sort of as especially focused on, grandparents raising grandkids, but it's the kinship component. I mean, it can be across the family, and the caregiving component is such a strong element, and the unique challenges that again, people across generations raising young families can have. So,
absolutely.
Excellent. Any questions for Kristen? Well wishes. I'm sure we all have well wishes.
Congratulations.
Thank you. Thank you so much. I look forward to, learning more about each of you, and just really appreciate the opportunity to introduce myself.
Excellent. Well, we've put your email in the chat and your bio sketch, so we will look forward to staying in touch. I know you need to run to another meetings, but we certainly appreciate having had you here. And for the group here, we hope to introduce new and incoming folks throughout our coffee chat series in the future. So with that, I am going to turn things over, thank you, Kristen, to Dr. Karen Heltzer, who will really be leading the policy conversation today, 3 years into the IRA. So with that, Karen, I will hand it over to you.
Thank you so much, Michelle, and thank you all so much for being here on the call today. We have a fantastic panel of experts that can really talk about what we've seen in the last 3 years since the Inflation Reduction Act was signed into law. It was actually signed into law August 16th, so just about at the 3-year mark. And then really trying to look at what's ahead. I will let the panelists introduce themselves and their amazing organizations, because they will do a much better job than I do. But really quickly on the call, we have Brian Nyquist, who is the president and CEO of the National Infusion Center Association, Danine Ciccone, who is the vice president of advocacy and policy at the Cancer Support Community, and Sue Passion, who is the president and CEO of the Alliance for Aging Research. Sue, since we're talking about the Inflation Reduction Act, which is having dramatic changes to Medicare, and your alliance is representing seniors, maybe we can start with you. Oh, and in the chat, you will see the amazing bios of our panelists. So can you briefly introduce yourself, your organization, and maybe some of the impacts of the Inflation Reduction Act that you've already seen on the seniors that you represent?
Oh, absolutely. And thank you so much for having me today and having the Alliance for Aging Research participate. And this is such a great forum. So for those who aren't familiar with us, the Alliance for Aging Research is the leading nonprofit organization that's dedicated to changing the narrative to achieve healthy aging and equitable access to care. We were started back in 1986, and we strive for a culture that embraces healthy aging as a greater good. And we value science and investments that advance dignity, independence, and equity. And we work in both public policy and health education. And our website is agingresearch.org. And in terms of the Inflation Reduction Act, we have dug in its various iterations since before the law was passed and after the law was passed. And the reason why is, as you said, Karen, there's a lot that impacts Medicare. There are some things that are very good about it, in that it created the first ever cap on out-of-pocket costs in Part D, and it created a new benefit for beneficiaries to be able to smooth out the existing out-of-pocket costs that they do have in Part D, depending on if they reach a certain threshold of cost. But then there are some other things that we've been worried about with related to direct negotiation, which sounds great on the surface, but has really been much more about saving money for the Medicare program than it has been for saving money for Medicare beneficiaries. And in fact, both from anecdotes as well as some studies that have now been published, there's been a lot of problems with changes to beneficiary formularies and more movement of different medications that people take around so that you might have to pay more. It might not be covered the same way it used to be. So the Alliance has really done both in health education as well as in public policy, a lot of work to try to educate the public and policymakers. And I'm sure we'll dig in a little bit more on all that today.
Absolutely. To maybe follow up on a couple of things that you mentioned. You mentioned smoothing. I know that's a new process that was implemented at the beginning of this year. Are seniors aware of this? How has the uptake been? Are we seeing the benefits that we're hoping, or is there more to be done?
Yeah, I mean, the smoothing program is formally known as the Medicare Prescription Payment Program. And CMS has really not done a lot to promote the program, which is why a lot of groups that are here on the call today and our group and groups like the National Health Council have done a tremendous amount to try to raise attention to it because it's a really good potential benefit. But in terms of how many people have taken advantage of it, it's unclear because CMS is not required to be transparent about who signed up for it. They also didn't take all of our feedback from our group as well as a number of other groups to allow for sign up for where you get your medications at the pharmacy counter. So folks need to call their insurance company 24 hours before they initiate the smoothing program. And if they don't do it, they can't take advantage of it. So there's different aspects to it that have become, a little, make it a little bit harder than it needs to be. And we have videos and materials about this at a special webpage, loweroutofpocketcosts.org, if folks want to learn more.
Fantastic. And you mentioned some of the negative impacts that you've already seen from the Inflation Reduction Act. Can you explain a little bit more why? And I know you commissioned a paper a little while ago that really did a deep dive. So can you talk a little bit more about what changes you have seen and why?
Sure. I mean, this is getting into, on the policy side of things, the federal agency that manages the Medicare program, the Centers for Medicare and Medicaid Services, they are not that unlike an insurance company, they're a public payer rather than a private insurance company, but sometimes they act a bit like a private insurance company. And so we have, met with them about some concerns that we have. And typically, or oftentimes, I should say, the staff will say, well, we're not allowed to do this or that. So the reason why we commissioned this report from this group called Manat was to show that, in fact, they can, and their statute allows them to do a lot more than they say that they're allowed to do. And in particular, we had a bunch of recommendations in this report because of things that we have been seeing and that we were worried about. So the recommendations included things like a public watch list for specific adverse formulary decisions that CMS won't approve to keep the drug plan sponsors from narrowing their formularies, the list of drugs that they say that they'll cover. We wanted CMS to commit additional resources to doing these types of formulary reviews before they start to harm beneficiaries. We wanted them to publicly identify where plans have to cover more than 2 drugs per category or class to ensure that the formularies have adequate options for patients, especially the ones that have been selected and ones that are most commonly used, which are a lot of the selected medications under the Medicare negotiation program. And we also wanted to make sure that the drugs that were selected for negotiation be given preferred formulary status. So we had all these different recommendations. And, our steps after that, CMS has not enacted much of this. They have done some changes that we've requested in various comment periods, along with many other advocacy groups that are here. But we recently got some report language into appropriations on the Senate side to push them along a little bit more to have Congress give them a directive to, allow for some positive changes. And, including where we are really trying to push so that this smoothing program that we just recently talked about, that folks are able to sign up at their pharmacy counter. And that's another thing we're trying to do is there'll be a bill introduced this fall that would direct CMS to do just that. And then the last thing I think I want to mention that a lot of people are worried about is something called effectuation. And that's when the implementation process for the negotiated pricing goes into effect at the pharmacy level. And the first round of negotiated pricing for the first 10 drugs that were selected goes into effect at the beginning of next January. But pharmacies, in particular community pharmacies, have really expressed worry that CMS has not done nearly enough to make sure that this is going to be a seamless process, either for pharmacies or for beneficiaries and patients. And the National Community Pharmacists Association did a survey that was conducted earlier this year in January, where 61% of independent pharmacists said that they're strongly considering not stocking one or more drugs with the prices that were negotiated under Medicare Part D. And an additional 33% have already decided not to stock one or more of the drugs. And the reason why is they haven't figured out cash flow problems and payment delays related to this implementation process. So there's a lot of, they always say it's in the details and that's what you have to worry about. And that's what we dig in on.
So help us understand this a little bit more. What's the impact on the seniors that you represent if their pharmacy is not stocking the drugs that is negotiated? In particular, these drugs were selected because they are widely used. What is the impact on the patient?
Yeah, I mean, it's, you can just sort of play it out. Everyone here, in terms of just having to find a pharmacy that does carry your medication, if there is one in your immediate area. And if you're in a rural community or even, a lower income, more urban community, you have to go further and you may not be able to find what you need. So it's not, really what I think a lot of older adults were kind of sold around this whole process, from who gets the savings, which is pretty much the Medicare program, not beneficiaries, to whether or not this would allow for better access. And in fact, what we're seeing, and in some of the initial studies, and MedPAC even, which is an advisory committee that helps the Medicare program and helps CMS, even they have called out some of these issues. So, there are problems to work through, and that's why it's important for all of us to work together to advocate.
Absolutely. And you mentioned that you already saw changes to formulary design, uptake and utilization management. And so it seems like there's so many additional barriers for patients to access their therapies. And as you mentioned, some of these changes are just about to go into effect. So I assume that you expect a lot to see a lot more going forward. I know Part B drugs will become negotiation eligible. And Brian, I will shift to you in a second because you represent the infusion centers that are administering these products. And I know there are lots of challenges around that as well. So you mentioned facturation, the fact that the first negotiated prices are going into effect at the beginning of next year. It sounds like maybe things aren't quite ready and there are lots of questions. Understanding we're at the end of August, so we don't have a lot of time, and it's really concerning to hear the statistics that you mentioned, and we will definitely see if we can share those resources in the chat, and we will follow up with those resources. But it does sound like there are lots of access barriers for the patients that were supposed to be helped.
Yeah. Yes. Thank you so much. I really appreciate the opportunity to speak about it. And we just would love for everybody to save the date on October 28th. We're going to be hosting another event with the Hill. It'll be a morning briefing during open enrollment to educate beneficiaries about, making sure that they reevaluate their plans and where they can go for resources at their state health insurance assistance programs. So October 28th, I think it's a Tuesday, and they're usually from like 8 to 10:30 a.m. Last year we had over 200,000 folks that watched, about 82,000 live. It was actually a record breaker for the Hill. So really invite any groups that are here that have resources. We are happy and thrilled to pitch, SHIP, to pitch, CSC, other groups, and National Health Council, all that. You guys are all so important to this. And we need to create the resources because CMS, unfortunately, is not.
And I do definitely want to make sure that we come back to you a little later and that we talk about some of the solutions that you all are advocating for. But Brian, you represent both the National Infusion Center Association and the Infusion Access Foundation. Can you talk a little bit about those two organizations and why there are two different organizations and some of the impacts of the Inflation Reduction Act that you are already seeing?
Yeah, absolutely. Well, good morning and good afternoon, everyone. I appreciate the opportunity to join this important discussion. I'm Brian Nyquist. I'm president and CEO of the National Infusion Center Association, and I founded the Infusion Access Foundation and continue to serve in a volunteer capacity on that board of directors. So in my first years leading NICA, it became clear the infusion market needed two separate but coordinated voices, one for patients and one for providers. And that is why we formed the Infusion Access Foundation in 2020. IAF is a 501c3 disease agnostic patient advocacy organization formed to support and empower the people who rely on infusion or injection medicines. Led by Alicia Barron, the IAF team tackles issues that threaten patient access, equips patient with self-advocacy tools brings them together at the annual Champions Weekend to train them how to effectively amplify their voice, to interject the patient perspective in major policy discussions, and then takes those empowered voices to Capitol Hill every year to drive patient-centered change. NICA, on the other hand, is a 501c6 trade association protecting non-hospital community-based infusion centers. Our job at NICA is to make sure these centers remain viable and scalable because patients need places to get their therapies outside of the hospital. Together, the two organizations create a balanced approach to advocacy, patients raising their voices for access, and providers making sure they are sustainable sites of care. That strategic collaboration has been incredibly powerful over the last 5 years. And so before I get into kind of some of the impacts that we're seeing before and after IRA, love to talk a little bit about why we care, why we're involved in advocacy around IRA. So I want to start with an important reminder. Affordability and access are not the same thing. The Inflation Reduction Act was passed with the goal of lowering drug costs, and it does have some important wins for patients that Sue mentioned, like capping out-of-pocket spending in Part D, allowing costs to be spread out over the year, capping insulin at $35 a month, and making vaccines free for seniors. Those are real, tangible benefits, and we really need to celebrate those wins. But here's the problem. Those gains don't necessarily translate to physician-administered infusion and injection drugs, the therapies for cancer, autoimmune diseases, and other complex chronic conditions. If the government sets a price so low that providers can't cover their costs to purchase and administer those drugs, they simply won't be able to offer them to their communities. And when that happens, patients lose. Think about it. Your mother battling cancer may not be able to get her infusion in her community clinic anymore. Instead, she'll be pushed into a hospital outpatient department, which is less convenient, often harder to access, and the most expensive site of care in the system. So ironically, a policy meant to make drugs more affordable could actually drive up costs while making access harder. And the ripple effects are serious. It could disrupt the fragile biosimilar market, it could chill innovation, and it puts community infusion centers at risk of closure. At the end of the day, patients need the right drug at the right time in the right setting. Lower prices on paper doesn't mean much if the real world result is patients being cut off from their therapies that they need. That is why NICA is engaged on this. We support price reforms that help patients, but not reforms that cut them off from care. And that's why we're in litigation, not to undo the good parts of the IRA, but to protect patients from being collateral damage. So even before the IRA, we've seen some troubling signs in the market: tighter formularies, biosimilars priced underwater, insurers forcing providers to get drugs through their own specialty pharmacies, and even higher premiums for patients. States are also creating prescription drug affordability boards that set upper payment limits on provider reimbursements that puts providers and therefore access at risk. Looking ahead, as Part B drugs become subject to government price setting in 2026, I expect access to decline. And because Medicare sets the tone for commercial insurance, those government set prices will spill over quickly across the entire payer mix. That means infusion providers could be underwater across all payers. And patients who have been stable on their medications for years may force or face switches, delays, or loss of access altogether.
So it really strikes me here a lot of similarities to what Sue has said, similar to the effectuation problem where you have the potential challenge of having less access because fewer pharmacies might be able to carry the drug. It seems like there are lots of similarities here. Brian, can you help us understand a little bit more how physicians are reimbursed and how that for the administration of Part B drugs and how that might be tied to some of the impacts of the Inflation Reduction Act on access to Part B drugs?
Yeah, absolutely. So infusion providers generally acquire medications under what's called the buy and bill model. They purchase the drug, they maintain inventory, and then they administer that drug. So because they take ownership of the drug, there are two components to their total reimbursement. There's a payment for the drug, and then there's a payment for the professional services to furnish that particular medication. Now, the challenge is on the professional service payment side, providers are grossly underwater, very much undercompensated for the total cost to coordinate care for these patients. So they are so reliant on that drug payment to offset losses on the professional service payment to maintain economic viability of providing these services to their community. So what the IRA will do is essentially significantly reduce those drug payments, that sole lever that infusion providers have, again, to offset losses on the professional service side, and make delivery of those medications selected for negotiation and price setting financially inviable to continue supporting.
And a lot of the physician reimbursement costs don't change regardless of what type of drug it is. So it sounds like the reimbursement is tied to the price of the drug, but the fact that but it doesn't cost less to administer that drug compared to a different drug. Is that in a nutshell correct?
Yeah, so great point. I did fail to mention that that drug payment reimbursement is based on the average sales price of the drug, so it's directly tied to drug pricing, unfortunately. Um, so to your point, Karen, there may be some differences in the total cost to coordinate care by medication, depending on the therapeutic area and some of the pre-administration requirements, monitoring requirements, labs, diagnostics, those types of things. Like for anti-amyloid therapies for Alzheimer's disease require PET scans, ongoing MRIs to monitor for ARIA. And so they also require registry and a patient registry. So there's a little bit more administrative burden associated with those medications than many other medications that they're administering. But for the most part, I would say total cost to coordinate care is similar across these provider administered medications.
And then there's also, I believe, a spillover or concerns about the fact that Medicare prices impact prices in other markets.
Yeah, absolutely. So Medicare is the incubator for the entire insurance market. Once the government sets a maximum fair price for Part B drugs, commercial insurers will quickly adopt those prices. That means all patients, not just seniors, could lose access to those therapies. There's also a technical but important ripple here. Unless we can reverse this component in the Medicare physician fee schedule, these government set prices will be blended into the formulas Medicare uses to determine provider reimbursement. And that reimbursement erosion will push many community providers underwater. So between commercial spillover and reimbursement erosion, patients relying on those therapies may face very real risk of losing access.
I see a lot of nodding. So what would that mean for the seniors that you represent?
I mean, there's already been drop-offs in provider participation in Medicare, and this would just aggravate it even more. And everything that Brian said, I agree.
And Deneen, you represent the cancer community, and I know Part B drugs as well as Part D drugs are a huge part for your community. Again, can you start maybe by briefly introducing yourself, introducing cancer support community, and what I learned recently is your connection to Goldust Club, and maybe talk about that a little bit, and then talk about why you are so concerned about the IRA and what impact you've already seen on the cancer community.
Yeah, absolutely. Thank you, Karen, for the invitation. So, yes, I'm Deneen Saccone, Vice President of Policy and Advocacy at Cancer Support Community. So, to give you a little bit of background on who we are a national nonprofit of 200 network partner locations, primarily located in the United States, where we provide free psychosocial support services to all people impacted by cancer. So, that's patients, caregivers, survivors, providing them the care they need. I'd like to say we provide the wraparound care, right? When someone's undergoing treatment, they're receiving that care and services, but we provide that psychosocial support, emotional support, and even through our helpline, some financial support services. So it's pretty much tailored to the unique needs of that person to support them through that journey. And so who we are as Cancer Support Community, our story is we became Cancer Support Community in 2009, but just a little bit of background, just to pull back a little bit. It actually started by two organizations, one called the Wellness Community and the other one called Gilda's Club. So the Wellness Community started in believe 1982 in Santa Monica, California, in a yellow house. It was by a doctor whose wife, Harriet, was diagnosed with cancer. And he decided, during her journey, he recognized, there are no services out there, psychosocial support services for people impacted by cancer. And so they created the Wellness Community where they provided those free supports. Now, in 1986, for those of you who remember Gilda Radner, she was one of the original cast members of Saturday Night Live. She unfortunately was diagnosed with ovarian cancer and actually attended the wellness community and received the psychosocial support services. And she became a really big champion for the wellness community and the services and support they provided throughout her journey. Sadly, she passed away in 1989, but her family created the Gilda's Club in 1995 in her honor throughout the United States. And in 2009, Cancer Support Community was created where we joined together the wellness community and Gilda's Club to expand the reach and providing those free, no-cost psychosocial support services for people impacted by cancer. So that is who we are at our mission, at our core, is we meet people where they are and provide them the services they need. Why we got involved in the unintended consequences as it relates to the Inflation Reduction Act drug price negotiation program, it's all about access. It's all about affordability. It's all about respecting and prioritizing patients' quality of life, patients' treatment goals, and just what hope means to having access to life-saving medication. So we got involved in the Inflation Reduction Act by doing a few things. One, for the past few years, we've hosted every year an Inflation Reduction Act summit where we bring together interest holders, patient advocacy groups, industry partners, healthcare innovators, where we come together and decide as a group, how can we ensure that the patient and caregiver voice are included and top of mind, and how clinical benefit is being defined as part of the Medicare drug price negotiation program? So we're really looking at this from how are we ensuring, as a partner with CMS, that what matters to patients, quality of life, patient reported outcomes, endpoints, treatment goals, how are we ensuring that when you define clinical benefit, you're really factoring in and keeping as the baseline, right, the foundation, what matters to patients, and that's really informing meaningfully how the drug price negotiation program is being implemented. And so what we did is we created some patient-centered principles, consensus-based patient-centered principles that came out of our first Inflation Reduction Act Summit that really keeps the focus on the patient. We talk about creating a feedback loop for patient and caregiver communities to be able to share with CMS in a real meaningful way if there are any access barriers, if there are any access concerns. We also talk about working with patient navigators in the community that can really help explain and dispel some of the myths or barriers in a plain language way, how the Medicare drug price negotiation program is working for them. We also talk about, continuing to collect real world evidence as data evolves, because remember, our focus is always on ensuring that the patient and caregiver voice are front and center. and the implementation of this program. So that's how we got involved. That's what we've been doing for, the past few years. And we have our IRA summit coming up next month in Washington, D.C., where we're going to continue this conversation on how we keep patient and caregiver voice and what matters to patient front and center. And another reason why we got involved, which I think is not a surprise to many of you here, is that Medicare beneficiaries are typically those that are the most impacted. The prevalence of cancer is higher in Medicare beneficiaries, right? And so I think, according to the American Cancer Society, about 7 out of 10 cancer deaths are associated with Medicare beneficiaries. So there's a prevalence, right? Number one, there's just a need for access. Number two, and because of our engagement with the community, it's just so imperative that how this program is implemented really is truly patient-centered and keeps patients and caregivers top of mind.
And I know you shared some of the amazing resources that you've put together. I put them in the chat, but if you have information on the summit, definitely would love to share that too. I know you all have done such an amazing job being part of and helping to inform the patient listening sessions.
Yes.
And I know, Sue, you have done that as well. Would love to go a little bit deeper and see what some of your, both of your experiences have been. But before we go there, just I think you mentioned that you're already seeing some impacts on formularies, utilization
Yes.
management, etc. Can you talk a little bit more about what you've seen for your community already? And with cancer, I know every minute for treatment counts. What do these delays, what do these barriers to treatment, what do they mean to the patients that you represent?
Yeah, absolutely. So a couple of things we're saying. So one, we are beginning to hear that there are becoming some formulary access challenges that certain drugs are not um, on formulary. So, for example, drugs that were price negotiated are on formulary and the therapeutic alternatives are not. And again, as cancer support community and as others here on this call, what matters to us is that patients have a wide array of treatment alternatives available because shared decision making is so critically important. So hearing that there's another unintended consequence as it relates to access is something that we're very much engaged in and focusing on the formulary access. Number two, we are also monitoring utilization management, prior authorization, step therapy, step edits, for example. We know, so I did some work with DLA Piper. They're doing a couple of analyses, kind of looking at formulary placement, utilization management, as a result of the IRA. And some of the work we did back in February, there was a report that came out in February. Now, I'm speaking from the perspective of oncology drugs, right? So what we saw looking at our initial baseline is that for the oncology drugs, because oncology is a protected class, right? Meaning that by law, Medicare has to cover all or substantially all drugs on the formulary. While we're seeing that those drugs are covered, there is a high prevalence of prior authorization to get access to those drugs. And we're seeing even more being broken down by Medicare Advantage and prescription drug standalone, right? And in addition to that, we're also seeing, so we're also understanding that some Medicare Advantage plans have limited some of their networks, made them narrow, and aren't necessarily participating with academic medical centers, which may be more likely to prescribe newer treatment alternatives. And so some cancer patients may be having to make the choice of, do I keep my doctor or do I keep access to the drug, right? So those are some of the decisions and trade-offs that we're beginning to hear and that we're monitoring for in the oncology space.
I see a lot of head nodding, so I assume that you're seeing similar trends.
Oh, yeah, for sure. And there, as I mentioned, I'm MedPAC who advises the Medicare program. They voiced their concern in their most recent annual report. And then there have been a couple of studies, I think out of Avalier, one out of USC, Schaefer, showing that, this is costing beneficiaries. And it's also just And I just from the perspective of at the individual level, I mean, I'm a family caregiver for my mom, and I arrange my mom's medications every week. And my mom has dementia, but even, she can tell still when something changes up, even if they change up like the generic at the pharmacy counter and it's like a different color, or if it's a different, and that can be upsetting. You don't know what you're taking. It doesn't look the same. What is it? So at the individual level, and we have tried to express this to the Part D group at CMS, and I don't know. Eventually, I'm hoping that we will break through. But I don't think they don't think about these things. And again, they say that's not their role. And we would argue they need to make it their role because they're supposed to be serving, these same individuals that are very upset about a lot of these changes that they're seeing.
And Brian, I'm sure that in the Part B, so physician-administered market infusion centers, you're seeing similar challenges where limitations on access can probably have a huge impact on patients' ability to access treatments, in particular in rural areas, and in particular with your role with the patient community. Can you talk a little bit about like, what concerns you're seeing there around more utilization management and more restrictions in kind of your part of the world as the Inflation Reduction Act um, as Part B drugs start becoming negotiation eligible?
Yeah, I mean, my concerns with really any access threat is, if patients can't get their medication, what are they gonna do? And when we're talking about biologic medicines for complex chronic conditions, they're going to pivot from wellness management with a medical benefit drug and little to no other healthcare service consumption to a state of disease flare management in the most expensive care settings with increased reliance on healthcare, right? So emergency department presentation, inpatient setting to stabilize that patient so they can be outpatient again. Um, I think that's obviously worst case scenario. Best case scenario is they can afford the increased cost share liability of getting their medication to the hospital setting. But I'm yet to meet a patient who's been at a hospital and a non-hospital care setting that would want to go back to the hospital setting for a number of reasons. So, I mean, that would be my response in terms of whatever that access threat manifests as. Those are the outcomes that we're concerned about.
And
Karen, I
yes.
just wanted to mention one more issue that I think we don't talk about enough, which is, when you switch medications up on people, it's not just a matter of, oh, this looks different if I take, 12 pills a day or something. Oftentimes there are instructions that you need to follow, and most of the medications that are being selected are serious medications. They're
Yeah.
not for minor issues. So if you're switching your oral anticoagulant, for example, you need to titrate down and you need to, have an appropriate switch. And that should be overseen by your doctor, not just at the pharmacy where they just give it to you in a brown bag.
Yeah.
But that's kind of, also what's going on here. And that also worries us just from a perspective of adverse event or people just dropping their medication because they just don't feel like it's familiar to them anymore. And they don't really have autonomy, as, with their physicians. To kind of navigate what is best for them. And then the last thing I just wanted to say is Deneen used the phrase therapeutic equivalent, which is something that CMS, came up with. And therapeutic equivalent makes it seem like it's the exact same, doesn't matter what you take. But for example, again, going back to the anticoagulants for like atrial fibrillation, they consider warfarin therapeutically equivalent to the oral anticoagulants. It's very, very different in terms of management, how you have to take it. You've got to go to a warfarin clinic to get measured, all these different things. So the way that they are determining what is therapeutic equivalence is really quite random. And in fact, there have been journal articles that have said as such outright. And that's something else that I think we need a little bit more advocacy on.
And I'm glad you said that. Not trying to take over your, because I know you want to open this up. But to Sue's point, and we didn't really talk about this, but Sue and I participated in some of those patient roundtable listening sessions. And there were a list of questions that they asked. So there were four oncology drugs that were selected, and CSC participated in each of those roundtables. And when the question of therapeutic alternative came up, you know, our position is always. So I should just back up and say, for those who aren't familiar with CSC, we actually have a research and training institute that has a cancer experience registry that collects longitudinal information from cancer patients and survivors based off of the condition that they have, and they follow them throughout the year, so they can start as a patient, become a survivor, and continue on. And we use a lot of those learnings and that information. We use that to inform our responses or our participation in those patient listening sessions. And I'm saying this because when it came to the part about therapeutic alternatives, we reiterated time and time again that you're talking about individuals, you're talking about people. They're not monoliths. When we look at people, we look at what are your treatment goals? What are your quality of life outcomes? What matters most to you? If it's a person who wants to spend more time with their family, maybe having more energy and less fatigue is more important to them than another prescription drug that has a different type of side effect. And so those are the types of considerations that we impressed upon them, that you're talking about people. There's a humanistic value to this. There's a need for flexibility. There's a need for autonomy with the patient and their physician, and there's a need to trust that they're going to do what is right for them, and you can't just do a one size fit all.
Absolutely. And I know in many therapeutic areas, including, I think, oncology, non-medical switching can have all these downstream effects too, where maybe a therapy doesn't work anymore if you have to switch from one to another. And I think it all goes back to how do you value impact to patient? How do you think about what matters to patients? Um, I want to make sure that we have some time for questions. I do want to shift to some of the solutions. Deneen, I know one of the unintended consequences of the Inflation Reduction Act that we haven't talked about is that disincentivization of biologics for the small
Mhm.
molecule drugs. And I know you, as well as Sue, have done a lot
Yes.
of advocacy on EPIC. So I was wondering if you can explain the issue a little bit, what it means to the patients that you support, and how EPIC could help.
Yes, so Cancer Support Community supports the EPIC Act, Ensuring Pathways to Innovative Cures Act, and we actually led a couple of sign-on letters with others in the patient advocacy community to encourage Congress to pass the EPIC Act, and we also sent a letter to Administrator Oz, Dr. Oz, also saying that to us, this is an example of patient-centered policy that really keeps the patient at the core. And we say that because what the EPIC Act is solutioning for is an unintended consequence of the IRA that basically says that small molecule drugs, so those pill form, versus a biologic or larger molecule drug, for example, often administered in your physician office, the negotiation period for which they are eligible to CMS starts not at the same time. So, for example, biologics get 13 years and small molecule drugs get 11 years. That that unnecessary disruption or just not having that same parity may actually lead, which we don't want to see, may actually discourage or disincentivize research and development into additional treatment alternatives and outcomes for small molecule drugs. Because again, for the oncology community, we're beginning to see a lot more treatment alternatives being available as a small molecule drug in the pill form. We also know through research from our Research and Training Institute that oncology patients prefer small molecule drugs if at all possible because it's easier, right? They don't have to travel to an infusion center. So what the EPIC Act does is say, let's equalize and just say that for small molecule and biologics, it's 13 years following FDA approval that they are eligible and that they are included in the drug price negotiation program. And that is why we support that because we're always front and center about making sure patients have access, as much access as they can to treatment outcomes and treatment alternatives. And that is why we support the EPIC Act. And I'm heartened to say It's not just in the oncology community. It's the Alzheimer's disease community. It's mental health. It's autoimmune. There's broad support among the patient advocacy community for passage of the EPIC Act.
And so I know that's been a priority for you and
Yes,
your community as well.
absolutely.
Yeah, I mean, for older adults, it's also just, it's much easier to be able to get small molecule drugs, which are typically in like a pill or a tablet form, because those are the ones that you go to the pharmacy for versus having to go to your doctor's office or the hospital. You go get those medications when you need those medications. But, so this disincentive, which creates this, 4-year disparity, 913, is a disincentive for manufacturers to actually make more of those types of medications. And there was a recent report from the Information Technology and Innovation Foundation, which found that small molecule drug investment has dropped 70% since the IRA's passage. Or since it was first drafted, I should say. And there was a survey of drug manufacturers that found that 78% reported they expected to cancel early stage pipeline projects due to this discrepancy. So this is an easy fix. There seems to be, there's certainly bipartisan sponsorship of the legislation, and we hope that there'll be an opportunity to get it into an end of the year legislative package. And we're planning a webinar on this for patient advocacy groups in early October. We don't have a definitive date yet, otherwise I would give it to you, but it is coming.
Fantastic. And Brian, on the flip side, we know that patient access to infused medicines, to Part B drugs is so important. As you explained, there are lots of worries about future access because of the reimbursement challenges that we talked about. Can you talk a little bit about some of the solutions that are out there, including the Protecting Patient Access to Cancer and Complex Therapies Act, which is a mouthful? Can you tell us briefly what that would do?
Yeah, absolutely. So the act that you referenced, the Protecting Patient Access to Cancer and Complex Therapies Act, is a common sense legislative fix. It would preserve the current provider reimbursement methodology, insulating providers from the effects of government price setting, essentially. Manufacturers would still pay the government the difference, but providers wouldn't be left holding the bag. So that means patients would continue to have access to their therapies in community settings, and providers could stay viable. This isn't about resisting reform, it's about making reform patient-centered. That's why we need patient advocacy organizations involved and engaged in supporting it. In terms of where you could learn more about that act, NICA has a policy brief on both the IRA and the Protecting Patient Access to Cancer and Complex Therapies Act. I can share those with the bio team to share with you all if that's helpful. But again, it's important to emphasize this legislative bill isn't about resisting reform. It's about making that reform patient-centered.
Fantastic. And yes, we would love to share those resources. So what I've heard and what I've learned, and thank you so much for your time today, what I've learned is that there are lots of challenges. There are challenges that we've already seen where the Inflation Reduction Act has restricted access to therapies. There are more concerns coming as the first negotiated prices are going into effect as Part B drugs are becoming negotiation eligible and some of the reimbursement challenges aren't fixed. And as we are starting to see increased disincentives for drug development. We are pretty much out of time, but I do want to see if there are any burning questions from the audience.
This is Eric.
Yes, Eric?
Eric Hartman. If you chat, that is a resource, it would be really great if bio can make sure those resources that have been posted are included as a follow-up to this discussion, because we certainly need it.
Absolutely. We will make sure that we circulate all the wonderful resources that have been shared and that have been mentioned with the audience. And yes, I think we need everybody on deck to address these issues.
Thank you.
With that, thank you so much to our esteemed panelists. I learned so much. There's so much left to do, but thank you, and thank you for the work that you all are doing to help ensure patient access.
Thanks for having us.
Thank
Thanks for
you.
the opportunity.
Thanks, everyone.
Thank you.
Thank you so
Thank you.
much.
Bye.
Bye.